Thank you for introducing me, Chang Lee. Am I your best friend? Right?
Right.
Good afternoon, ladies and gentlemen. I'm Jae Young Lee from the Catholic University of Korea. I'm a pediatric cardiologist, and very welcome to this meeting. My topic today is a sequential segmental approach to congenital heart disease. Before my presentation, I'd like to give my special thanks to Dr. Sejun Yu from the Hospital for Sick Children, Toronto, Canada, for teaching me cardiac pathology and giving me a nice illustrations. Objective of today's topic is to understand how logically approach to congenital heart disease and describe congenital heart malformations. So we need some system for this purpose. So sequential segmental analysis. As you know, heart mass has 3 segments: atriums, ventricles, and atrial trunk. And we have also 2 ATRIOVENTRICULAR junctions: atrial myocardium joined to ventricular mass atrioventricular junction, and ventricular mass give rise to atrial trunks, ventriculo-arterial junction. So basic rule is that to identify chamber is based on the recognizable anatomical feature, not based on the embryological assumption or related variable organs. Just intrinsic morphological feature is the base. 3 facets of the cardiac makeups are morphology of each component and connections between components and the spatial relationship. So sequential segmental approach is flow diagram is the following. First step is identify morphological features of each segment: left or right atrium, left or morphologically right ventricle, atrial trunks. And then for this method, as I mentioned, morphological method is used. Just intrinsic anatomical feature. And then we can establish the atrial relationship or situs. And next step is ventricular relationship or ventricular topology. And then we can attention to the mode of atrioventricular connection. And after identify the great arteries, and we can also establish the mode of ventricular arterial connection. And then we can describe visceral situs and associated cardiac anomalies. The first step is identification of atrial morphology. Atrium has several components: atrial appendage, venous component, vestibule, body, and septum. But the most constant component is atrial appendage. Other components are variable. This cast models nicely show the internal organ of the morphological right atrium and morphological left atrium. This is the superior vena cava, inferior vena cava, comprised of venous part, and the smooth vestibule is a muscular structure supporting tricuspid valve. In between, anterior aspect of the atrium, right atrial appendage. And the important structure in this cast is the pattern of pectinate muscle. In morphologically right atrium, the pectinate muscle extends from the atrium to the coronary sinus, extends all around the tricuspid valve. In contrast, morphological left atrium has very finger-shaped atrial appendage, and the pectinate muscle is usually confined to the atrial appendage. So the body and vestibule is very smooth. Once again, the internal structure we can see This is the right atrial appendage, and pectoral muscle extends all around the AV valve to the coronary sinus. This is the characteristic feature of morphologically right atrium. Instead, the left atrium had a smooth vestibule, and the pectoral muscle is just confined to the atrial appendage. And next step, ventricular morphology. Ventricle has several components to distinguish morphological right or left ventricle: apical trabecular component, AV valve morphology, and moderate bend. But the most constant component to identify ventricular morphology is apical trabecular component. As you can see here, the right morphological right ventricle, tricuspid valve, inlet part, and the outlet component, and this is the apical trabecular component. Very coarse trabeculation, you can see. This is the characteristic feature of a morphological right ventricle. Instead, this morphological left ventricle has very smooth septal surface. This is the most consistent part. And then you can see this image, another additional feature of morphological right ventricle is the presence of a moderate bend, the muscular bend from septum to the free wall, just a septomarginal trabeculation. And then the additional characteristic is the attachment of AV valve. This is the tricuspid valve. This is mitral valve hinge point. And there is offset between two valves. More apically placed AV valve is usually tricuspid valve. So this chamber is morphologically right ventricle. Arterial trunks, there is no intrinsic distinctive features in this case, so we can identify based on the branching pattern. So aorta gives rise to brachiocephalic trunk and vessels to the body, and the pulmonary trunk is bifurcated or to run to pulmonary trunk. This is a common atrial trunk, and this is a solitary atrial trunk. So now we can move to the atrial arrangement. There are basically 4 atrial arrangement. This is the usual atrial arrangement: morphological right atrium in the right, morphologically left atrium in the left. And this is a mirror images, that's the opposite position. But sometimes patients have bilaterally morphological right atrium. We can call right isomerism or isomerism of right atrial appendage. This is the bilaterally morphologically left atrial. This is the left isomerism or isomerism of left atrial appendage. So body arrangement is usually concordant to atrial arrangement. This is the usual arrangement you can see here: 3-lobed right lung, short bronchus, 2-lobed left lung, and long bronchus, and liver in the right, and stomach spleen in the left. The opposite situation is mirror imaged, so-called situs inversus. Sometimes you can see a right isomerism, bilaterally lobed, 3-lobed lungs, and bilaterally short bronchus. And this is the left isomerism associated with polysplenia, is a bilaterally long bronchus and bilaterally 2-lobed lungs. And the ventricular relationship we can talk about. You can see morphological right ventricle is right. We D-loop ventricular relationship. This is the morphological right ventricle is in the left. This is the left ventricular relationship. But sometimes we have a very complex heart, such as twisted heart or crisscross heart. The ventricular location is very unexpected. So to identify ventricular loop, ventricular topology we can use. In this heart, tricuspid valve and pulmonary valve and outlet, this is the septal surface of the right ventricle. So just finger is a tragus valve inlet, and thumb in the inlet part, finger indicating outlet part, and palmar surface facing interventricular septum. Just in this case, only a right hand can fit this morphology. So in this case, right hand topology or the loop, we can say. And the other case is the inner part, only part aorta in congenitally corrected transposition of great artery. Septal surface is here. In this anatomy, only left hand can fit this anatomy. So we can call, in this case, left-hand topology or the L loop. And we can move to AV connections. There are two types of main AV connections, biventricular AV connection and univentricular AV connection. Biventricular AV connection means each atrium connected to own ventricles, but in contrast, univentricular AV connection, total AV junction is joined to one ventricle. This is univentricular AV connection. And when the AV valve is straddled or overridden, we can apply 50% rule. In this case, right AV valve, more than 50% of right AV valve committed to the right ventricle. In this case, biventricular AV connection. But in this case, right AV valve committed to morphological left ventricle, and two AV valves are committed to the one chamber. This is the case of univentricular AV connection. And biventricular AV connections have modes of biventricular AV connections are follows: concordant, morphologically RA, LV, and morphologically LA, LV. But in this case, RA committed to the morphologic LV, LA committed to morphologic RV. This is the discordant atrioventricular connection in such congenitally corrected transposition of great arteries. But atrial arrangement is ambiguous. In two cases, there is a biventricular AV connection, but concordant or discordant we cannot say, so this is ambiguous AV connection. And let's move to univentricular AV connection. Two types of univentricular AV connection: double inlet ventricles and absent one AV valve. So double inlet ventricles, the two AV valves are committed to one ventricle, usually dominant morphological LV, but sometimes morphological right ventricle. In this case, double inlet left ventricle. In this case, double inlet right ventricle. The another situation is absent one AV valve. This is absence of right AV connection. There is no connection between morphological right atrium and small right ventricle. In this case, left AV connection is absent. Morphological left atrium has no connection with left ventricle. This is mitral atresia. This is the common type of tricuspid atresia. So when we have double inlet ventricle, the dominant ventricle can be morphological left or morphological right, but it's not easy to identify exactly. But if the dominant LV is dominant ventricle is morphologically left, the rudimentary chamber or incomplete chamber is located almost always anterior superior aspect of a ventricular mass and far from crux cordis. But dominant ventricle is morphologically right. The rudimentary chamber is almost always inferior posterior aspect of the total ventricular mass and adjacent to or connected to crux cordis. This is the anatomical feature in double inlet ventricle. This cartoon nicely shows the typical pattern of double inlet left ventricle. Two AV valves are joined to morphological left ventricle, and there is a small rudimentary chamber in the anterior superior aspect of the ventricular mass and give rise to aorta, and there is a communication between these two chambers, previously called bulboventricular foramen. But this is the morphological right ventricle. We can say easily this is the VSD. And situation of absent AV connection, this is the right AV valve atresia. This is the most common form of tricuspid atresia. Just there is no connection between right atrium and right ventricle, and in between fibromuscular tissue is interposed. This is the typical type of tricuspid atresia, but there is a connection, but there is no perforation in the AV valve. In two cases, also the blood from two atriums join to the one dominant ventricle. So this is the case of univentricular AV connection. And this is the specimen of the tricuspid atresia. There is no connection between RA and RV. Left side absent AV valve is also the same case. There is no communication between LA and LV, and this is imperforated mitral valve case. Also, both atrium join to morphological right ventricle. This is the case of specimen. And then finally, I'd like to talk about VA connection. Hemodynamics is determined by connections, concordant, discordant, and double outlet and single outlet. This is the concordant VA connection. LV give rise to aorta, RV give rise to pulmonary artery. This is a usual normal heart. But in this case, LV give rise to pulmonary trunk, and RV give rise to aorta. This is concordant ventriculo-arterial connection. But in some situation, one ventricle give rise to predominant arterial trunks. This is a double outlet VA connection, double outlet ventricle. In some case, common trunk and solitary trunk. When the seminal valve overrides the septum, just 50% rule is also applied. In this case, PA is committed to more than 50% to the LV. So this is the discordant VA connection. And in this case, pulmonary artery is more committed to the right ventricle. So in this case, double outlet right ventricle. So great arterial relationship is the relative position of aorta. Position of aorta relative to pulmonary trunk. In the normal heart, the aorta is located posterior, right posterior aspect to the pulmonary trunk. In complete transposition of great arteries, the aorta is located right anterior aspect of the pulmonary trunk. And congenitally corrected transposition of great artery, not always, but usually, the aorta is located left anterior aspect of the pulmonary trunk. So previously we called L transposition. So a logical approach and systemic description is very important. So you can see we have cardiac mass, atrium, ventricle, atrial trunk, and two AV or VA junctions. So we can diagnose especially complex congenital heart disease as this sequential segmental analysis. Thank you very much for your attention.